Welcome and thank you for joining. My name is Trixie Thibodeau, Health Educator for Community Health at Atlantic Health Systems. Today's webinar, What You Need to Know About Colorectal Cancer, and being presented by Dr. Babin. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try to get through all the questions at the end of the presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these programs and other resources, or for additional dates and times, please call 1-844-472-8499. The first step to a healthier heart is knowing your risk level for heart disease. Take 2 minutes to complete our online quiz and get your individual results.
Thank you for your time. Good afternoon. My name is Cleo Babin. I'm a general surgeon at Chilton Medical Center. I actually just started in October. I joined Dr. Bacosi's group. And a little bit about me, I just, like I said, I started in October. Just graduated from residency back in June, moved back from Pittsburgh, but I'm originally from New Jersey. And it's been, a real pleasure working at Atlantic Health and getting to know the medical community a little bit more, especially at Chilton. So without further ado, I'll get started. So I'll be presenting what you need to know about colorectal cancer. Very hot topic, especially recently with changing guidelines. So first of all, nothing to disclose. I have no conflicts of interest. So despite huge advancements in cancer medicine, and specifically in colon and rectal cancer management, we have a lot of ways to go when it comes to taking full advantage of the resources we've gained over the years through research and reducing not only the numbers of cases of colon and rectal cancer that develop every year, but also the severity at the time of diagnosis. So where does the discrepancy lie between the availability of resources required to improve these numbers and their actual widespread utilization in our country? I think we can make some progress in closing this gap by spreading some basic but crucial knowledge that can make a difference in how and when we as a community seek medical care. So starting off with some stats in the United States, what do you think the risk of developing colon or rectal cancer is in the average person's lifetime? You'll be shocked to know it's about 1 in 23 for men and 1 in 25 for women. The American Cancer Society's projections for colon and rectal cancer incidence in the United States in 2004 is about more than 100,000 new cases of colon cancer and over 46,000 new cases of rectal cancer. And this is for this coming year. So still pretty alarming numbers despite all the progress we've made. So these are our learning objectives. Hopefully by the end of this presentation, you'll be able to describe some of these, at least in a little bit of detail. So one, I want by the end of this lecture for you to have a basic understanding of colorectal cancer, to identify risk factors and prevention strategies for colorectal cancer, to increase your awareness of warning signs, to be able to choose a suitable screening option, and understand the basics of diagnostic testing for colorectal cancer and its relevant management. So first, I just want to discuss, global overview of the basics. So the GI tract. The colon and rectum make up the last portion of the gastrointestinal tract, the anatomy of which is depicted in the center of the slide in very many colors. The GI tract is part of the digestive system, which functions to take food in, such as pizza on the left hand of the screen. It can also process or digest it, keep or absorb essentials or fuel like vitamins, minerals, and calories you see on the right side of the screen. Absorb that into the bloodstream and expel waste, which is the stool in this photo on the left. The goal is to absorb what the body can use and get rid of what it can't. So you starting in the mouth, we start, chewing our food. Food is introduced, we swallow it, it travels down our esophagus into our stomach. The stomach churns it, mixes it with gastric juices. before heading down to the small intestine, as you can see in the orange in the middle of the cartoon's abdomen, where it mixes with juices from the liver and pancreas to continue breaking down the food in the small intestine. Eventually, it's absorbed into the nutrients and the minerals are absorbed in the small intestine and make its way into the colon. And the colon is the last, process where the food gets the ability to reabsorb water and electrolytes before heading down to the rectum and evacuating the stool. All right. So trying to simplify, especially since we're just discussing the basics, but I want to give a, detailed representation of what cancer is. We hear about cancer, different types of cancer, and all cancers, behave differently, but there are some general concepts that underlie the understanding of what cancer is. So cancer is when a tumor or a group of overgrowing cells has the potential to invade or spread to other parts of the body. A tumor is when cells in the body grow or replicate abnormally, and there are three types of tumors that you might hear about. They're not always malignant or cancerous. They're benign tumors, so overgrowing cells that do not have the potential to spread or metastasize. Malignant, which are cancerous, so just like cancer, can invade or spread to other organs. And then there's that third in between category, pre-malignant. So it's not yet cancerous, but it's that step right before cancer. So it has the potential to progress to cancer. Our cells, have many different mechanisms to maintain balance in our bodies, largely instructed by DNA, which is, the genetic component that allows, a cell to either continue growing or to divide, but also to get rid of cells that are abnormal or should no longer continue replicating. So as an example, this assembly line is I'm having a hard time getting to this. Excuse me. So this picture in the middle is an assembly line cartoon that helps to depict this process of maintaining balance. So if you picture these machines on the assembly line in a factory that's preparing its product in the boxes along a conveyor belt, each machine contributes to one aspect of the product along the assembly line. The final product is dependent on the individual contributions of each of the participants on the assembly line. Two of the individual contributors are the employee in the blue, right by that on switch. And her job is to turn the machine on when appropriate. And then another is the manager in the red, in the lower left hand of the screen, whose job is to tell the employee to stop the machine when production is complete. Just like in this depiction, there are many contributors or genes, basically like the DNA instructions that I talked about before, that are responsible for this whole process to run smoothly and is programmed. Cells uncontrollably replicate when they contain mutations or alterations in their DNA that either stimulate the cells to multiply continuously, so as if that employee jams the machine and the power lever is stuck on the on position. So it continues to replicate and produce boxes, way too many product and without the ability to stop it. Alternatively, another way is these mutations can cause cells to ignore the directions to stop replicating. So as if that manager falls asleep during her shift, and instead of telling the employee to stop what she's doing, this cartoon got a little screwed up. But so let's just say that employee and the manager in the red is unable to instruct the employee to turn the machine off. Then production, goes into overdrive again, just like before. Sorry. This is a Mac. I think this is a Mac issue. My cartoons got a little messed up, but okay. So how do these mutations even happen? Actually, the cells in our body naturally make mistakes as they divide. It's one of the jobs of our immune system to clean these mistakes up as they happen. So if you look at this first picture, sort of the idea that, there's a watchman or the immune system that's able to pinpoint that foreign body or a bug, virus, what have you, that's able to be swallowed by other cells in the immune system. And that's how, they keep these dangers in check. So compared to our previous example, the manager sleeps through a shift, doesn't stop production, you get a big mess, way too many boxes. At this point, the supervisor, let's just say, another person who's looking over the floor um, and who's the manager's boss, would do the cleanup like the immune system and replace the manager with someone more competent. This restores proper function in the whole system, and production can go as planned. However, tumor cells harbor select mutations which allow them to evade immune system screening. This is a multi-stage process that results in unregulated growth. So the more mutations a person has, or the worse the screening function is, like the immune system, the greater the likelihood that a mutation can develop into cancer. So now throw into the mix not only the malfunctioning, employee and manager, but a malfunctioning machine that throws in a red box when there's supposed to be brown boxes. So now you're overproducing incorrect boxes. So that's yet another mutation that throws a wrench in the plan and then continues to overproduce. So that, general concept in the simplest of terms is the way that, multiple mutations after mutations then end up becoming so abnormal it becomes something like cancer or a tumor. Now, this can also happen when there's not proper oversight. So when there's no supervisor on the floor able to correct these mistakes before they become disasters like we have here. And so that represents an under-functioning immune system. So as our cells divide, mistakes happen naturally. We talked about that. And that's part of the process. But if a person has increased rate of mutations, it increases their chance of cancer developing because those cells have a greater chance of surviving that immune system. So examples of that, it's like UV radiation, so the environment or genetics, if they start off with mutations already that are inherited from their parents, a person has an increased likelihood of those mutations propagating and not getting caught by their immune system. Thankfully, we do have an immune system that has advanced mechanisms to get rid of mutations. But if a patient has decreased immune function, there's an increased chance that a cancer can develop. So if you think about somebody who has increased, immune system impairment because of medications, because of their genetics, because of chronic conditions such as type 2 diabetes is a way that some patients have impaired immune function, then it can, again, increase the likelihood that these mistakes don't get corrected and can turn into malignancy like you see in the cartoon below. So why is cancer dangerous? So what's the actual process of it harming us? So, we talked about overproduction of cells, but how does that do anything to our bodies? Why do people die from cancer? So it harms us when it spreads. And it spreads by growing and invading into nearby organs or by metastasis or traveling to other parts of the body. Because cancer cells have to survive all these defense mechanisms to exist, they're very resilient, very resourceful. So they continue to grow without a signal to tell them to grow or despite a signal to tell them to stop. They also provide their own nutrients by attracting blood vessels. So they're, hijacking the body's blood vessels and nutrients so that they can continue to grow in abundance. Um, and they hide from the immune system. So the immune system, in fact, protects it, even though it's supposed to be defending against cancer. Um, there are many ways that cancers can avoid or evade the immune system function. And so harm occurs when, like I said, the cancer continues to grow and can cause blockage or erosion, can strangulate other organs in the body, can disrupt organ function. So that's, those are the results of aggressive local invasion. But also by completely depleting a patient's energy sources, causing weight loss, fatigue, malaise, anemia, nutrient deficiencies. This all causes a lot of harm to the body and makes a patient with cancer a lot less resilient. And then, like we talked about, metastasis and mass effect by spreading to other organs and establishing tumors in other organs that can invade other organs' functions as well and increase the risk of recurrence. And so there are other causes of death from cancer as well: infection, sepsis, a lot of the results from treatment, which can be pretty toxic, especially in the context of malnutrition and the patient's immune system being on overdrive for this. So specifically, how does this relate to colorectal cancer? What is colorectal cancer specifically? So it's cancer of the cells of the colon or the rectum. Often it's the cells that line the colon and rectum. So colon is also another term in case you have heard other terms for it: large intestine or large bowel, just to not confuse everybody. And the primary functions of the colon are water absorption, nutrient absorption, also release of potassium and chloride, so electrolytes, and it also packages and transports the waste. And then the rectum collects, detects the waste, and also evacuates it. So how does colorectal cancer develop? So frequently there's a common pathway that originates as a benign or a premalignant polyp. Many people might have heard of polyps from a colorectal cancer screening, like a colonoscopy, and we'll talk about that a little bit more. So polyp can progress over time to become cancerous. Certain types of polyps have different abilities to do so, but the progression from an adenoma or an adenomatous polyp to cancer takes at least 10 years in most people. Polyps are, by definition, just growths or small bumps within the lining of the colon or rectum. It can be from, normal cells that just overgrow. It can be from abnormal cells that overgrow. Like I said, there is a range of different types of polyps, and each different type of polyp has a different risk of turning into a malignancy. So in the lower left-hand corner is a picture of what, if you sliced a piece of colon lengthwise, that you could see the inside and what a polyp looks like. So there are different types of polyps that can be found within the colon and rectum, like I said, some of which are completely harmless. There are others that have the potential to turn into cancer, such as adenomas or adenomatous polyps. Those are pre-malignant type, but depending on their characteristics can have different, risks. So low risk or high risk based on the microscopic features, that you can see on a biopsy, for example. And so, depending on the growth patterns, so tubulovillous growth patterns, these are getting into the weeds, but this is something that a pathologist, after a biopsy is taken during a colonoscopy, they can see and describe. And, as we move, tubular is the least likely to become cancer, and villous is the most. There are serrated adenomas versus sessile serrated. Dysplasia is the amount of changes that the cells have undergone, basically like the mutations and result in, disorganized cell structure. And based on how much dysplasia there is, that also changes the risk, as well as the number of polyps the patient has, the size, how the polyp was removed. These are all very important in terms of establishing cancer risk. And, these are just examples. Of course, the formatting has gone a little awry, but on the lower hand side, this is what a pathologist would see under the microscope as you progress from hyperplasia, which is just overgrowth, to abnormal cells like dysplasia, to cancer all the way on the right. And then, based on these risks of polyps, if you have a polyp removed from a colonoscopy, it changes how frequently you need colonoscopies, because you're either at, an okay low risk or a high risk, and you need more frequent evaluation. So, why is learning about colorectal cancer important for everybody? Now, a lot of what I just described was, a basic understanding, but a little bit more than just basic. But it's important to understand the details of, why we care about colorectal cancer, why we can prevent it, what the research is doing to help move things forward so we prevent colorectal cancer and deaths from colorectal cancer. It is very common. It is the third most common cancer for both women and men. Um, about 10% of all cancer cases, and the second leading cause of cancer deaths in the world. Um, so it obviously makes a huge impact on our public health. Um, Now, we had an overall decline since the 1980s in the amount of new cases of colorectal cancer. But that was mostly in the older population because those were the ones who were getting screened with the advent of colonoscopy screening. Um, and we've seen over the past 5 to 10 years that the trend of improvement has not been as robust. Um, and we'll discuss a little bit later why we feel that is, but it's estimated that by 2040, the incidence of colorectal cancer will increase about 63%, and the colorectal cancer related deaths will increase to about 73%. Um, and in particular, adults less than 50 years old, rates of colorectal cancer have been increasing since the mid 1990s by about 1 to 2% per year. So that's still very, very low risk of having colon cancer below 50, but it's more than, the trend is alarming, and it's certainly more. 18,000 new colorectal cases in patients under 50 in 2023 is more than we would want. So in looking at these statistics, there are three major takeaways that, I'm going to pinpoint during the rest of the talk. But so we can learn from the decline in the incidence rates since the mid 1980s is attributable to the screening initiative. So colorectal screening has made a huge impact in preventing colon cancer and rectal cancer, catching it early as well, so decreased deaths. And then research also has correlated the fact that over the past 5 to 10 years, those trends are not, as great. Research correlates that there are modifiable lifestyle changes that can be responsible for this trend. So, potentially things that we can change and improve with widespread education to improve these numbers even more. So if we target normal or low risk individuals, to understanding also warning signs, so signs that patients develop just before their diagnosis of colorectal cancer, so that the average risk population can start to think about them and seek care earlier. It would prompt earlier screening and make a measurable impact on those younger patient outcomes that are, increasing every year. So theoretically, we can prevent and more effectively treat an even larger portion of colorectal cancer if we master the above interventions. So it's important to think about how. So it's part of you know, one of the learning objectives of this talk is to equitably provide widespread colorectal cancer knowledge, but also preventive resources to both patients and providers. Knowledge is very important, especially in this, in colorectal cancer. So in these three takeaways that I just mentioned, there are two prevention strategies that I'm going to touch on. So the colorectal screening initiatives, that's number one. And then number two is the modifiable lifestyle changes, as well as the warning signs that, the patient population and the provider population can be more aware of. So I'll start first with the first prevention strategy. So screening. So if you define cancer screening, it's surveying a patient for cancer when they have not demonstrated any signs or symptoms of having that cancer. And that's really important because if you can identify a lesion that will become cancer eventually or has a risk to do that, then you can prevent the actual cancer from developing. So that doesn't count as a new colorectal cancer case, for example. So the earlier an abnormality is detected, the more effectively we can act on it. And so because of that, it's not only colorectal cancer screening is a major contributor to prevention, but it also allows colorectal cancer to be detected early and thus decrease the death rate from colorectal cancer or the mortality rate. because of screening. So we'll touch on that, the earlier detection of colorectal cancer first, and then we'll go back to the prevention. So the reason it's so effective is the earlier a cancer is diagnosed, the more effectively we can treat it. And you can see that by the numbers that, first of all, on average, all stages of colorectal cancer in the US has a 65% 5-year survival rate. But if you look at the breakdown stage by stage, or local, the SEER stage, essentially, which is localized, regional, or distant. Localized is stage 1 and 2. So the cancer is still early on, hasn't gone to lymph nodes, hasn't metastasized. The 5-year survival rate for colon cancer is 91% and 90% for rectal cancer. So very robust. So the earlier we find the cancer, the more able we are to treat it with greater outcomes significantly. You see distant, or metastatic cancer, the survival rate goes down to 13% and 17%. So these are big differences. So now, who and when do we screen? So we know screening is effective, but when do we initiate screening? And for this, it's essential that we identify who's at high risk and who's not. And that's the first step. There are many factors that go into that calculation, but basically a couple of big tenets. So age, your past medical history, family history, genetic disorders, social history, any symptoms that the patient has. And based on those, you get categorized high risk or average risk. We'll touch on these with a little bit more detail in a few slides, but it's important if you are categorized as high risk that you get screened, earlier, more frequently. You're on top of it. You understand your screening schedule, and you also communicate freely with your provider. So if any changes occur, or changes and even recommendations occur, that you're aware of it. Also, there's some role for genetic testing in some of these cases too. And so those are things that we don't expect a patient to know, but knowing that you are high risk, at least you can keep the lines of communication open. Okay. So more about, who exactly is high risk. So these are patients with what we call non-modifiable risk factors. So something that you can't change, basically. And these are the categories that automatically put you at a high risk category to trigger early colorectal cancer screening. So first of all, with age, you increase your likelihood of cancer overall. You have more mutations over time, and you have a weaker immune system as you age. So that's why, it used to be after 50, but after 45, colorectal cancer screening is recommended. If you have a family history of colorectal cancer, so specifically a first degree relative, so a parent, a brother, sister, or child, with colorectal cancer, that increases your risk. A patient should know how many of these first degree relatives they have. That's important, and what age they were diagnosed. And also, even if you have a first degree relative with a polyp, it's important to know that too. And this information you otherwise might not have thought to ask a family member, but knowing that it plays a role in your risk category is important. And if you yourself have a personal history of colorectal cancer or polyps, less than at an age earlier than 60 years old, you yourself are more likely to develop a new colorectal cancer. So that puts you at a different risk category, a higher one. And then there are a myriad of genetic familial syndromes, which is a small percentage of this high risk category, but any patient with FAP or familial adenomatous polyposis or Lynch syndrome, HNPCC, that's important because that's pretty aggressive screening, and then also, early treatment, preventive treatment. And lastly, inflammatory bowel disease or IBD, Crohn's or ulcerative colitis puts you at high risk automatically, and requires more frequent and earlier screening. So, this is nitty gritty. So it's just for informational purposes, and I won't necessarily go through every little recommendation, but it's important to know that, with a personal history of colorectal cancer, you have follow-up protocols after your treatment for the initial colorectal cancer, and that's something that you specifically discuss with your provider. And, same goes with if a polyp is found in your colonoscopy. I'm sure some of you have experience with that, that the provider tells you when you should report, come back for another colonoscopy, 10 years, 5, 3, sometimes even more frequently. Someone with a family history, like we talked about, a first-degree relative, or a high-risk polyp, so adenomatous, for example, that has high-risk features, um, then you start colorectal cancer screening with a colonoscopy either at age 40 or 10 years before the earliest diagnosis in the family, and then you're every 5 years versus an average risk person is every 10 years after 45. So, this makes a big difference in catching these things early. Um, and then if you have 2 or more first degree relatives at any age, that puts you at that high risk. There are some other breakdowns, but again, essentially needs to, if you know you're high risk or you think you might be at high risk, you need to talk to your provider to make sure that you're on schedule. Okay, so what if you don't classify as high risk? When do you screen? So if you're average risk, you start screening at 45 years old until 75. After 75 until 85, individual by individual basis, based on your risk factors, your life expectancy, et cetera. And that's a conversation that you have with your provider. Now this is new since, past couple of years, the recommendations decreased from 50 to 45. And, again, that's because of much more frequent um, an increase in incidence of colorectal cancer in the younger age group, so less than 50. Now, what type of screening? Again, we'll go over that with more detail, but depending on how you obtain your screening, so colonoscopy or another type of endoscopy, whether it's a CT scan or a stool test, it changes how frequently you need to get tested based on the accuracy of those tests. So if you're not high risk and you haven't reached screening age yet, so less than 45 years old, because cases of early onset colorectal cancer are rising, especially over the past several decades, how do we catch these few cases, but significant ones, early enough to effectively intervene? Because often younger patients who develop colorectal cancer or early onset colorectal cancer patients have more advanced and less treatable disease because it's so uncommon that they don't suspect it very, very often, and abnormal symptoms that they maybe should have sought treatment for, they brush off because it's unlikely to have colorectal cancer at such a young age. And so a couple of things that we can do off the bat, make sure, everyone who needs screening is screened. So everyone has to make sure whether they're high risk or average, that they're on top of their screening. And then make sure that you actually are average risk category. So you're investigating your family history, and, making sure that, your family's health records as they're pertinent to your, screening protocols. And then your modifiable risk. So 55% of colorectal cancer in the United States is attributable to potentially modifiable risk factors such as lifestyle, weight, diet, management of type 2 diabetes, for example. And then, another thing is educate, patients and providers on warning signs. So what are symptoms if you otherwise don't meet the criteria above, should prompt a medical evaluation? Should you go see your doctor when you're having a little bit of diarrhea or bloody stools? At what point do you seek care and push for care? So because it's so rare, we need to really make sure, the knowledge is there for these do not misdiagnoses from certain warning signs, both for patients and providers. So screening was a prevention strategy number one. Prevention strategy number two is if we target key behavioral changes that decrease our risk of developing cancer, then we can theoretically effectively reduce our lifetime risk. So, like I said before, a lot of these cases are thought to be attributable to modifiable factors, so things that we can change and improve. So just reiterating that cancer is caused by mutations or mistakes in DNA. Mutations happen naturally, but also increased risk of mutations and number of mutations are caused by DNA damage, sometimes by the environment, like chemicals in tobacco, smoke, or UV light, things that we can avoid or decrease our exposures to. Additionally, inherited mutations that were passed down from our parents can start us overall at a baseline higher risk level for further mutations in cancer. But mutations more at risk for becoming cancer. Mutations become more at risk for becoming cancer when you have an increased rate of mutations or a weakened immune system we talked about. So if we decrease the mutations or the rate of mutations, or we maintain or optimize our immune function, we can theoretically reduce our risk of colorectal cancer developing. And so to do that, we have to address these modifiable risk factors. Excuse me. So, for example, smoking cessation, cutting back on alcohol. These are, risk factors that we know increase not only, our risk of other types of cancer, but specifically colorectal cancer. Improving your diet with increased fiber has shown to decrease the risk, as well as decreasing red or processed meat. Increasing physical activity, weight loss, and diabetes prevention. These are all helpful things that we can do on a day-to-day basis to prevent the development of colorectal cancer. And then there's research that also shows long-term use of NSAIDs or non-steroidal anti-inflammatory drugs like aspirin, for example, reduces the risk, but it comes at a cost because you can have some serious side effects like a gastrointestinal bleed that can be life-threatening. So let me make sure. So yeah, accumulating research really highlights these tendencies that specifically increase our colorectal cancer risk, especially early onset. And a common thread is the increase in our body's baseline inflammatory state. And that's important because, this is something that you see in all of these lifestyle changes that we've made, that they cause an increase in the inflammation in the body, which is a process that is triggered naturally in the body when injury or irritation or disease occurs. And it can put your body immune system into overdrive and cause subsequent problems such as increased risk of colorectal cancer. Some of these lifestyle risks we talked about, so the diet, sedentary lifestyle, obesity, even just being overweight actually, but also the gut microbiome are important to touch on. That specifically is the bacterial environment that we contain in our GI tract. Not only does it have a big role in digestion and gastrointestinal function, but also immune function. It's largely affected by the food that we eat, our weight, our activity levels, medications, the chemicals in our food and air, our chronic diseases, etc. But a poor gut microbiome causes inflammation, or an unbalanced one too. And when the delicate balance within the bacterial environment is disrupted, it causes an increase in the bad bacteria, or causing toxin production and more inflammation. And again, increases your immune system and puts it into overdrive. So it's a battleground of inflammation, which can generate more mutations in DNA and increase the likelihood again of generating cancer. Additionally, it also helps the immune system bolster cancer cell growth because it does actually decrease the activity of the cancer fighting immune cells. And so this is almost a paradoxical issue that increases cancer growth even more. And it can also decrease the effectiveness of certain cancer fighting treatments as well. And along these lines, chronic diseases like IBD, like Crohn's or ulcerative colitis, or diabetes, those are chronic inflammatory disease states causing inflammation in the GI tract. And so it makes sense that they increase your risk for early onset colorectal cancer. And then, if we extrapolate that, factors like air and water pollution, chemicals in our food and soil, among other unnatural substances that we inadvertently introduce into our GI tracts could cause inflammation, DNA mutations within our colon rectum. So, in summary of these prevention strategies, um, one big bottom line is make sure that whether you're average or high risk, you're obtaining your appropriate screening for colorectal cancer. And then also you're aware of these lifestyle changes. So healthy diet, so high fruits and vegetable, high fiber diet, low red meat diet, no smoking tobacco, limiting your alcohol consumption, being active, not sedentary, avoiding obesity, and being overweight, and avoiding exposure to environmental risk factors. And then, lastly, that in terms of lifestyle, that if you suspect that you might have abnormal GI symptoms, speak with your healthcare provider right away, and make sure that you obtain the proper workup. So, a common question is why not just screen everybody? Um, and so then we would really be able to catch those young patients that develop colorectal cancer early. But the problem is we don't have unlimited, immediate, or equitable access to colonoscopies, for example. It's very resource intensive. Additionally, if we do, screen too often and non-selectively, we might intervene on patients that don't need any intervention, and that can actually cause more harm than benefit. And then also, what do we do with intermediate results because we screened, we found something, and we're not sure, what kind of effect it'll have on the cancer outcome. So we need to have refined criteria to initiate screening in patients that don't necessarily qualify for high risk or don't meet criteria for automatic screening for colorectal cancer. So, for one, you have to make sure that everyone who's due for screening gets screening because only 50% of those aged 50 to 54 years old are up to date. Now the criteria is even lower. So that means our numbers are probably even lower than that. And also up to 62% of patients with family history of colorectal cancer or high risk polyps are not up to date on age appropriate screening. So the lack of awareness on what your family history is and how that pertains to your colorectal screening process, you know, causes deficiencies in this as well. But then also when, a symptom is abnormal, this should trigger a workup. So if a patient doesn't seek medical attention for something that's clearly a red flag, because they don't know it's a red flag, that's important to address. Knowing what lifestyle changes to change or can reduce the risk, and those are all things that we can actually target rather than just screening everybody. So, what are warning signs? First of all, younger adults are more likely to ignore signs of colorectal cancer. So, when it's diagnosed, it's usually very advanced. Um, because it's so rare, especially under 45 years old, these patients won't otherwise undergo colorectal cancer screening. And the fewer or more subtle the signs, the longer it takes to get diagnosed. You can attribute these, subtle signs to other disease processes like a GI bug or something like that. But the more symptoms that you have, the more likely you are to seek medical attention. So, what are these red flags that we can clearly identify correlate with colorectal cancer? So things like changes in bowel habits, diarrhea, constipation, narrowing of the stool, those are important. If you have a blockage or a mass that's blocking the colon partially, you might have a harder time going to the bathroom and you can only, evacuate diarrhea or liquid stool or more narrow stool. So that's, something important to notice. That might be a little silly thing that you would never otherwise think about. Blood in the stool. So rectal bleeding is really important to keep an eye out. So either bright red blood or dark and tar-like the picture below. Those are important and red flags. Patients that have abdominal cramps, pain, or bloating that won't go away, not just, a transient symptom, but persistent. Patients that without trying or shedding weight, they're eating the same amount, they're not exercising more, kind of a quick, sudden weight loss without trying, their pants don't fit anymore all of a sudden. They might not even weigh themselves on a scale, but they can just tell or other people notice that they've lost weight. Patients that are constantly tired, lacking energy, even when they have enough rest. And then another big one is iron deficiency, anemia. So oftentimes these cancers shed blood, and so it might be microscopic. So you might not even see it in the stool, but it can be enough over time that causes anemia or decrease in hemoglobin. So, the goal is to be able to streamline the process. So you have these symptoms, and you're able to seek care and get a workup so that you can address an abnormality and treat it early if it is colorectal cancer. So for the provider, consider colonoscopy for any of these, red red flag warning signs. So like unexplained bloody stools, iron deficiency, anemia, together, should prompt workup with a colonoscopy because they're very strongly associated. If you add even more symptoms like abdominal pain, diarrhea, even though individually they're less associated, just having diarrhea doesn't prompt a workup for cancer. But in the greater context, with rectal bleeding and anemia, it should definitely ring warning bells. So, the workup for GI symptoms should be thorough, not just anybody with abdominal cramps, but the provider and the patient need to go through symptoms, specific symptoms, so that, we're not superfluous in terms of, uh, again, screening everybody. We don't have the resources for that. But we can be targeted in how we work these up and what the best process is for workup. So this is just some data from a study that showed the associations of patients from 18 to 64 years old who developed colorectal cancer and those who did not, and what kind of signs or symptoms they demonstrated in the 2 years leading up to the diagnosis. And the most strongly correlated symptoms were abdominal pain, rectal bleeding, diarrhea, and iron deficiency anemia. So these four were the most commonly associated with those who had colorectal cancer compared to those who didn't. And it was more of a robust finding in the younger patient population, so under 50 than over 50, possibly because over 50, these symptoms are a little bit more common and they're a little more abnormal in the younger patient population. And so the more of these symptoms that a patient has out of just these four simple ones, the more likely you should be to trigger a workup, or as a patient to push for a workup. Okay, so if you have warning signs, now what? What do you do? So, the top just is the reiterating the basics of screening, who should get screened. But you have to choose. There are a couple of different choices for screening tests. So bottom line, screening, any type of screening, even if it's a lower accuracy screening test, is better than no screening whatsoever. So there are a lot of things to consider when taking into consideration what screening will work best for the patient. But for one, patient preference is important, their medical condition, whether they can tolerate the procedure or not. If they're high risk, colonoscopy is the best, but everybody else, they have a lot more of a choice. And the reason is colonoscopy is the most sensitive test, as well as being able to actually diagnose and biopsy the patient. Also, you have to take into consideration the likelihood a patient will get the test and then continue to follow up. And so those are all things to consider. There are three types of screening choices. So endoscopic, like a colonoscopy or sigmoidoscopy. It's procedural, but very effective in detecting and confirming cancer. You can take biopsies through them. And they can also prevent cancer by removing precancerous polyps. Now there's a virtual colonoscopy, CT colonography is what it's called, non-invasive, but more expensive. And that's with imaging. And then stool tests, and we'll go through those in a second. So this is an example of endoscopic procedures. It's a thin, flexible lighted tube, both sigmoidoscopy and colonoscopy, where the endoscopist can look directly at the lining of the colon and rectum, and also take biopsy samples of polyps. And then you can, detect cancer early this way. This is just an example. Colonoscopy goes all the way through the colon, and sigmoidoscopy only goes through partial. Just because time reasons, we won't go through all this, but there are a lot of resources out there that can show you a video of what a colonoscopy entails. So colonoscopy, a lot of benefits. So it reduces your risk of developing colorectal cancer by up to 90%. You look at the entire colon and the rectum, the most sensitive of all the tests, and also is the only one that with sigmoidoscopy that can diagnose the test. And for average risk people, it's every 10 years. It's recommended starting at 45 years old. You need to do a colon prep beforehand to clean out the lining of the colon so that the endoscopist can actually see the lining, which is a laxative, and some pills that cause diarrhea the day before the test. So uncomfortable for some patients. And then you also need sedation for the procedure. And different types of sedation are available as well. So overall, for some patients, this might be a little too burdensome. And so that's why it's, not widely accepted as everyone's favorite screening test, but the risks are low, even though higher than some of the other screening tests, but still very low. And because it's such an effective test, it's a good one. Sigmoidoscopy, basically the same as the colonoscopy, except it only goes about 50% of this of the colon, essentially to the left-sided colon only and the rectum. Um, and so lower risk than colonoscopy, but you can still take polyps from the lower portion of the colon. Um, and it's a little less burdensome because sometimes it can be done in the office without sedation, and a patient can drive home or work afterwards. And this is done more frequently because it's less sensitive of a test, so every 5 years, or in combination with another test every 10. So CT colonography is like a virtual colonoscopy, looking at the lining of the colon by taking a myriad of pictures with 3D reconstructions. Patient still has to have a bowel prep to clean out the colon, and it entails, you know, puffing air through the colon via the rectum. Um, so it's a good test, but it is expensive, not always covered by insurance. There's radiation exposure from the CT scan, and if a polyp or abnormality is detected, you still need a colonoscopy for diagnosis and biopsy. There are a bunch of stool tests. There are two that just detect the blood in the stool and different mechanisms. The first and the second one, the FIT and the fecal occult blood testing or YF test. And then there's the Cologuard type test, which is the FIT DNA test. Looks at both DNA markers for cancer and then also blood in the stool, which is more specific and sensitive. That's something that can potentially be performed every 3 years. Basically, a patient at home gets a prescription for an at-home stool test. They take a sample of their stool for the first 2 tests and send it off. The Cologuard or FIT DNA test is an entire bowel movement in a box, and you ship it off to the company. But pretty effective and less invasive. So some people prefer that, and again, should be tailored to your preferences and abilities to get this done. So what happens if you have a positive test? What do you do next? So unless you already had a colonoscopy as your test, you have to obtain a colonoscopy and look to see if there's an abnormality or not. If there is, then the colonoscopist or endoscopist takes a biopsy or removes the abnormality. They try to do that in completion. Biopsy is just a sample of tissue. They send it off to the pathologist. If it's suspicious for cancer, they will tattoo it, meaning they would mark it with ink so that it can be looked at later. So if this turns out to be cancer and needs to be surgically removed, then the surgeon can actually identify it because of the tattoo. So after the biopsy is removed, doctor, which is called a pathologist, who specializes in looking microscopically at this tissue and analyzing it, takes a look at it. Usually takes about a week or two to prepare and to analyze the specimen, and then develops a pathology report, which is the final analysis. As an example of a pathology report you might get, so this can be from just a regular screening colonoscopy if they took a polyp. Even if it's benign, you'll get a report like this. It'll have your name, the date, location of where they took the biopsy, a diagnosis. Generally, that's the summary of what they found on the analysis as well as the clinical picture. So a patient was having diarrhea and they got a colonoscopy and they saw a mass or they saw a polyp. And then, there are some descriptions that the pathologist puts, which is something that how you see the specimen to the naked eye, the gross description, and also how they saw it under the microscope. So describing the cells. The pathology report is really important. It establishes the diagnosis and then also assists in grading and staging, which is, these are really important components in treating cancer. Looking at, the very minute details like cellular, molecular, genetic markers, it really guides treatment. And the grading or the features that they look at specifically within the cells will demonstrate how aggressive the individual cells are, the cancer is, or a benign polyp even is. And so a lot of information can be obtained by that. Staging, it's a big crucial component to get a biopsy for staging purposes. So it tells you how advanced it is, basically if it's localized to that one area, and then there are other factors that help to determine if any of that cancer is spread to local lymph nodes or widespread to other organs. But regardless, the results of these pathologic examinations are are reviewed by a multidisciplinary tumor board. They discuss your results and then discuss the treatment plan, and it's tailored for each person if a cancer is found. Now, this is just, sort of breakdown if you are diagnosed with a cancer, regardless of how advanced it is. You have to undergo physical exam with your doctor, labs, imaging, and this is like a baseline exam, so then they can compare in the future. They do the colonoscopy, examine the inside of the colon, biopsy, send to the pathologist. They look at genetic mutations or biomarkers that can help tailor the treatment options, give you other options, give you additional in addition to chemotherapy or surgery or radiation, and then stage the cancer. And then based on the staging and the testing, you have a couple of treatment options. And that's, surgery is one of them. So surgery is offered when the cancer is able to be completely removed and when the surgery increases a patient's survival. So it can be upfront. So you get diagnosed with cancer. Usually it's the local early stages in a resectable tumor that or a symptomatic patient that the surgery is done right away before any other treatments like chemo or radiation. Or it can be done after a chemo and or radiation treatment and restaging for more advanced disease. In general, a big advancement in colorectal cancer is if colorectal cancer is found to be metastatic. Surgery is not off the table if you can remove those metastatic tumors. And so that's a big change and basically upgrade in the treatment of metastatic cancer, colorectal cancer. And then again, based on the staging and test and molecular testing, chemotherapy and radiation can help to shrink the tumor and decrease the likelihood that the tumor recurs or spreads. That can make the surgery easier downstage, and in some advanced studies, even prevent the need for surgery in some rectal cancers. And then lastly, there's some more advanced targeted therapies or immunotherapies that's specific to the genetic expression, the genetic profile of your tumor. And those are, based on the multidisciplinary tumor boards. And these are just, the overall principles of if you were to have surgery for a cancer or even an advanced polyp. The general principles are to remove the cancer, make sure that the cancer doesn't invade the margins, basically, so that all borders of the removed tissue are negative for any cancer cells. Remove accompanying lymph nodes, which might have drained or associated with the cancer, and then make sure that the blood supply that remains is intact so that you can either put the colon back together in continuity, or you decide on creating a colostomy, which is a stool bag, essentially for drainage. These are different, types of resections or removals of different locations of colorectal cancer. And these are just some more pictures of what a, colostomy or an ileostomy look like, which are possibilities in colon or rectal cancer surgery. So a couple of take-home messages. So we want to know how to prevent colorectal cancer the best that we can. When in doubt, always ask your provider. But hopefully you will have come home with a couple of key points that if you demonstrate these certain symptoms, it puts your antennas up to seek medical care. Identify what lifestyle or behavioral changes you can make to decrease your risk of colorectal cancer, what you're already doing that might be increasing your risk, and see if you can modify those behaviors. If you have a non-modifiable risk factor, you can still do something about it by making sure that you're getting the screening that you need. Know when to request or insist, really push for further evaluation from your provider. And same thing with the provider, if you suspect something's going on, to really insist with their patients for further colorectal evaluation. Like I said, there are so many choices that can be just as thorough as the next, as long as you're getting screened. And then know what you can do to prepare, bring to your appointment, such as like family tree, medical documents, pathology results from previous colonoscopies, previous imaging, all these things, or even records of your daily bowel movements. Those are all super helpful in terms of making sure that you're getting the screening and the attention that you need for any changes. Because ultimately, early detection of colorectal cancer is key for a cure, and that's really important. So, with that being said, thank you so much for your time.
For joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has also been added to the chat for your convenience. And a special thank you to you, Dr. Babin, for dedicating your time and expertise today. If you have any additional questions or comments, please send us an email to communityhealth@atlantichealth.org, or you can give us a call at 1-844-472-8499. This concludes our webinar. Have a good day and a wonderful holiday. Thank you.